As we all know, cancer is a ruthless disease. According to the CDC, it kills nearly 600,000 people in the U.S. each year. The illness is relentless, refusing to leave the body without a fight. In many cases, doctors are forced to use aggressive treatments like chemotherapy in order to defeat it. And though chemo has saved millions of cancer patients, it comes at a price. In fact, chemotherapy often makes patients sicker than the cancer itself.
I could fall asleep at a drop of a hat. So for 6 months, the off weeks that I would have chemo every 2 weeks, and the week that I was having chemo, it would go for 3 full days straight. I had to bring a machine home for 2 days for 48 hours, and it was a full day in hospital. So it was full on, just exhaustion. It was pure exhaustion and nausea.
That's Sabrina Rojes. She's currently battling stage 4 colon cancer and is one of many patients who've become seriously ill from chemotherapy. These harmful symptoms are a product of chemo attacking cells that rapidly divide, such as cancer cells. But as it destroys the disease, it often attacks healthy cells as well. This damage can lead to exhaustion and nausea, like with Rojes, as well as hair loss, infections, and anemia. And though this treatment is effective in eradicating cancer, it's not always needed. Dr. Jeanne Tie is a medical oncologist at Peter MacCallum Cancer Centre in Melbourne, Australia. She's designed a blood test that can determine whether chemotherapy is necessary for each patient. Right now, her test is only compatible with colon cancer patients who have already received surgery.
The blood test we're doing is called circulating tumor DNA, or it's a form of liquid biopsy. And we use the tumor-informed approach where patient's bowel cancer that was removed, we look for mutation in those bowel cancer. And for individual patient, we find a set of mutations we can then track in the patient's blood. So we take the patient's blood.
The patient's blood is taken at 4 weeks post-surgery, then again at 7 weeks. The blood test is customized to each tumor's genetic profile and detects DNA mutations unique to each person's cancer. If no cancerous DNA, known as ctDNA, is detected in the test, then chemotherapy is not needed. This method is more precise than the traditional ones doctors use to assess whether a patient needs chemotherapy.
The way we decide if a patient needs chemotherapy or not is based on just looking at the cancer tissue that's been resected. There are certain features in them, such as how deep the cancer has gone into the bowel wall, whether there's some cancer cells present in the what we call lymph vessel within the tumor, and how well differentiated the tumor is, for example. So those are risk factors we look at. And then we decide if the patient at a slightly increased risk or lower risk of cancer relapse, and then we advise chemotherapy based on that. Now, the problem is a lot of these features are not weighted equally.
This approach also doesn't account for the fact that many patients can be cured through surgery alone. After most cancer procedures, doctors recommend chemotherapy as a precaution. However, if the surgery was successful, additional chemotherapy is not always needed. T says the decision to add chemo after surgery is a huge dilemma oncologists face, even though most patients won't end up needing it.
The majority of these patients are actually cured by surgery alone. We know a good proportion of these, over 80% of these, are actually cured by surgery alone. So not many of them will need chemotherapy, but the way we currently select chemotherapy is not precise. So this blood test is another tool that we add to our standard staging feature to help us decide who needs chemotherapy or not.
T's study involves nearly 500 colon cancer patients who'd already had surgery. In order to assess the need for additional chemo, one group received T's blood test, while the other was evaluated using traditional methods. Only 15% of the blood test patients needed chemotherapy, versus 28% from the control group. However, 93% of both groups were cancer-free after 2 years. So, even though fewer people in the blood test group received chemotherapy, both groups reported the same survival rates. T says this is because ctDNA negative patients tend to respond better to surgery.
They do extremely well to a point that the risk is like a stage 1 cancer, where we know that they don't benefit from adjuvant chemotherapy.
So if chemotherapy isn't always the best option, why is it still the main cancer treatment?
I think it's
because until now, we don't have a good way of selecting who needs chemotherapy or not. So we'd rather overtreat patient than undertreat patient. I think that's where the convention has been. There's this fear that could be undertreating patient, cancer may come back.
A fear shared by Rojas in the early stages of her treatment. At first, she thought that opting out of chemotherapy would be a mistake. However, after the treatment, not only had her cancer returned, it spread to her lungs. Now she wishes that she'd never received chemo in the first place.
For me, I was like, oh, this is why the cancer came back a second time, because they didn't give me chemo. So they didn't kill any stray cells that were carrying on. That was my belief. So I'm like, 6 months of chemo, mate, we're going to smash anything that's in my body. There is no way for it to come up. So it's inconceivable still to me that this has metastasized to my lungs. And I've got the symptoms, they're slowly, for how I felt 3 months ago to how I feel today is a very different story.
And though T recommends bypassing chemotherapy in some cases, she clarifies that doctors should never gamble with a patient's health. For ctDNA negative patients, the chance of recurrence is very low, but they're still regularly monitored by their oncologist. T's goal in creating this blood test is to avoid giving patients unnecessary chemotherapy, given the harsh nature of the treatment. Currently, blood tests similar to T's are being researched with pancreatic, lung, and breast cancer. These trials aim to find a way to destroy cancer cells without also destroying the patient. You can find more information about Dr. Jeanne Tie and Sabrina Rojas on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Twitter, and Instagram. Our associate producer this week is Grace Galanti. Our production manager is Jason Dickey. I'm Nancy Benson. Coming up next week on Radio Health Journal.
It is within our human consciousness to want to make connections to others, regardless of if those people are sitting next to you in the room or on a screen.
Have you ever felt a connection with someone you've never met?
Then a new test that accelerates care for patients with rheumatoid arthritis.
I would have been able to maybe get a diagnosis and not wait till it was so inflamed that I had trouble walking and getting out of bed and holding a cup of coffee with one hand.
All that and more on Radio Health Journal. I'm Reed Pence, the producer and host of Radio Health Journal. If you like listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
I have to say, I'm really glad I took the road I did, because it gave me a lot of characteristics that I'm thankful for.
One man's journey from playing pro in the NFL to researching mathematics at Harvard. Then,
who wants to read about bloody war in Ukraine? Who wants to read about 19 kids getting assassinated in Texas?
Why fewer people are keeping up with media outlets these days. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Radio Health Journal and Viewpoints on your favorite radio station. And subscribe and listen anytime on Apple Podcasts, Google Play, and Spotify. Also, follow us on Instagram and Twitter at Radio Health Journal.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.